everybody, and welcome to this meeting of the Health Scrutiny Committee, which is being broadcast live as of now. Just before we get into the agenda, just a quick explanation from myself. I am going to make an early departure, probably just before 12. I've got an important call that I need to go and take. So if you do see me leave, that is what I'm going for. And I'll just be passing over to the Vice Chair, Councillor Wright. Item 1 is the minutes of the last meeting held on the 1st of July 2025. Can I accept the minutes as a true and accurate record, please? Any that were in attendance on the day? Okay. True and accurate? Yeah. Yeah. So, yeah, take vote. Yeah. So, all in favour of it being a true and accurate record? Yeah, carried. Thank you. Apologies for absence. James, do we have any apologies?
Okay, Chair, we have received apologies from Councillor Terry Cox for other reasons. We've also received apologies from Councillor Alan Byte, who has been substituted today by Councillor Joseph Rich. And we've also had apologies from Councillor Jonathan Wheeler for other reasons, and has been substituted today by Councillor Keith Girling. Thank you, Chair.
Thank you. Declarations of interest. Do any members present have any disclosable pecuniary interest to declare? No. And do any members present have any private interest, pecuniary or non-pecuniary, to declare? No. Lovely stuff. Move on to item number 4, which is the NHFT transformation of crisis and community mental health services. So the next item is for consideration is a report from the Healthcare Trust, which outlines the progress in respect of transformation and pathway design for crisis and community mental health services. I would like to welcome representatives from the Healthcare Trust. So we have Jan Senzia, who is the Executive Director for Partnerships and Strategy, Joseph Sullivan, who is the Deputy Director for Mental Health Group, and Jane O'Neill, who is the Clinical Lead for Crisis Service. Jan, would you like to introduce the report? Sorry.
Thank you very much, Chair, and thank you for inviting us today. We have been to Scrutiny Committee a couple of times over the last 18 months or so, and just to set a little bit of background to that, members will know that back in January 2024, the then Secretary of State for Health commissioned a report into Notts Healthcare Services based on 2 or 3 key events. One was clearly the horrendous killings by Valdo Callicane in Nottingham in June 2023. Also the awarding of, if I can put it that way, of inadequate a CQC report for Rampton and our delivery of services at Rampton, and there were other inadequate reports around our mental health services as well. That special review that was commissioned was called a Section 48 review. That took place, that review, over February and March in 2024, and there were a number of recommendations from that review that the CQC put forward, which were accepted by the Secretary of State and by ourselves, and we have been working on delivering actions against those recommendations ever since. What we're here today to describe is 2 in particular, one around our crisis services, and there were a couple of recommendations specifically around our crisis services for people suffering mental health crisis, and the other was around our local mental health teams. One of the things that the report identified was that we had at the time 11 local mental health teams, but they were not operating in consistent fashion. There weren't necessarily the same services available to people in those different teams, and also we were operating different processes across those different teams. So it was difficult at the time for us to have a really firm handle, for example, on how many people were waiting and how we were keeping people safe while they were waiting. So there were a number of issues that came out from that report, and as I say, we've been working on them ever since. What we're going to do today is to describe work in progress. So we do not think that we have finished the job yet by any means. We've got more to do, but we have been very, very active over the last 18 months in tackling the issues that we accepted that we needed to tackle. I think it's fair to say that we have seen improvements, and Joe and Jane will be able to describe those in more detail in our crisis services. In our local mental health teams, equally, there have been improvements, but also we identified the need to have a pretty whole-scale look at our pathways, the ways in which people access and use our services across the communities, across the county, and indeed the city. And we are embarking on that kind of radical, if you like, relook at our pathways, but we're not anywhere near the end of that journey yet. So what we'll describe to you today, as I say, is very much a step along the journey. What we would like to invite members to do is, we're not going to do a presentation. Joe will add a few words to what I've said, but then we're really inviting questions. And then if there are any particular areas where members would like more and more detailed information, we'd be very, very happy to come back at a subsequent committee meeting to give that information. So I'll hand over to Joe.
Thanks, Jan, and thank you, Chair, for the invitation to attend Scrutiny today. So I'm Joe Sullivan, I'm the Deputy Director for the Mental Health Care Group. We are proposing to take the report as read today, but I do want to just take the opportunity to just highlight some of the information to members this morning, which I think will be helpful for the questions and also the scrutiny of the report. So the report is separated into two particular sections. The first relates to our crisis services, and we're very pleased to have Jane here with us today from the service. And the second is in relation to the community teams, which Jan has referred to. I think it's really important to recognise that this morning that whilst we've separated the report into two sections, it's important to recognise that we are absolutely striving towards ensuring that there is a coherent, seamless and integrated pathway for mental health. And actually all parts of today's report and things that are not included in the report are interconnected. So, for example, we don't today talk about our inpatient services within the report in much detail. But actually what we recognise is that we need to have that seamless pathway, and that's what we are striving to do. I think it's also really important to echo what Jan's talked about there, is that the report is a point in time and where we are at the current point in our improvement journey, and we have a significant way to go. We believe we have made significant progress against the areas in the report, but we recognise there are still significant actions to do, which is what we're striving to do as articulated in the report. What I want to draw members' attention to in both sections of the report, there are notes in relation to the improvement actions which have been undertaken, and also the challenges which are impacting upon that particular part of the pathway, whether that be crisis or community. And actually I would draw members' attention to those areas particularly because they directly align to what we call our integrated improvement plan in terms of driving forward the activity. I do just want to touch upon, particularly in the community pathway, initially the areas of action undertaken. So the section 48 and the subsequent inspections that were undertaken of the trust identified significant challenges around risk, and as Jan has referred to, significant risks in relation to monitoring and understanding the needs of our patients, and particularly those patients waiting to receive a service. So outlined in the report are a number of steps, and there has been a real focus in the previous period on ensuring coherency and consistency across our services. We recognise at the time of the section 48 that there was inconsistency across all of our services in how we responded to the needs of our patients. We have now really focused in on ensuring that we have consistent practices across our teams, and that those consistent practices and standards are embedded across all of our teams. And I just want to touch upon a few areas of that. Firstly, the Safe Now tool. There was a real recognition, as Jan articulated, that at the time of the Section 48, there was real concern around our understanding of the needs of our patients, but also risk management. The Safe Now tool, which is a live interactive dashboard, brings together a number of key indicators relating to the care of our patients and the care of our patients, whether they are on a waiting list or receiving an active assessment or care. And that dashboard has been praised nationally in terms of the bringing together of key information that allows us on a daily basis to monitor the needs and presentations of our patients to ensure that our responses from a care perspective are responsive at that time. I think the second is also that we recognise we continue to have waits within our community teams, but what we have significantly focused on is ensuring that patients are supported to wait well, and ensuring that all patients have clear information, advice and guidance around support that they can access whilst waiting, and that might be directly from the trust or voluntary and community and social enterprise sector. It may be from our partners, but also understanding how we can support in terms of self-care, but also when needs escalate and actually how they engage with our services at that point. I think it's really important to recognise within the improvement actions undertaken, as highlighted both within crisis and community, there has been a particular focus to get the foundations right of safe and safe today, safe right now, to allow us to embed and develop some of that continuous improvement as we go forward. So I just wanted to touch upon those two particular points because I think they are really important in terms of the conversation today. But I don't want to take any more time up and we welcome the questions and scrutiny of the committee and are more than happy to provide further detail and insight into practice as well as we move through the report. So once again, thank you, Chair.
Everything? Yep, lovely. Okay, so Jan, Joseph and Jane, thank you for the introduction of the reports. And I'd now like to open up the discussion to the committee. Councillor Gurley.
Yeah, thanks, Chairman. Forgive me if I get this wrong, because there's a little bit confusing in the report. So the Trust Integrated Improvement Board and the Trust Patient Service and the Patient Safety Quality Improvement Programme report monthly, pursuing Operational Excellence Trust Integrated Improvement Programme, Trust Integrated Improvement Programme, Portfolio Board, Oversight and Insurance Group, who then report to the Integrated Improvement Board and the Improvement Oversight Committee. Is that what happens?
So shall I take that, Chair, if that's okay? So,
did anybody else get confused by that?
It's not entirely the way it happens, but I think what you rightly highlight is the degree of scrutiny and governance that there is on the trust, and we do genuinely welcome that scrutiny and that governance. It can at times feel overwhelming, particularly for our staff. But let me try and paint the picture. We have an integrated improvement plan that has about 14 key projects on it, and they are split into 5 programmes of work, one of which is pursuing operational excellence, one of which is patient safety and quality improvement. Those all report to an integrated improvement plan portfolio board, which is an internal trust-led board. It's chaired by our chief executive, Ifti Majid. In turn, from there, that reports through to a board committee, which is called the Improvement Oversight Committee, which is chaired by our chair, Paul Devlin. That meets quarterly and provides that non-executive oversight as well as the executive oversight. But in addition to that, we report monthly through to our regulators, which are NHS England, the Integrated Care Board, and that is the one that's called the Improvement and Assurance Oversight Group, which it all feels rather, I know, mind-boggling to think of all those different layers of scrutiny, but that is how it works. So the Improvement and Assurance Oversight Group is externally chaired. It's not a trust group. We are held to account by that group. The other two are our internal governance mechanisms. And then just to make it even more complex, When we think that we have achieved one of the key recommendations, we take that to something called the Evidence and Assurance Oversight Group. Far too many of these groups, I know. That is externally chaired as well by a very experienced improvement director from Norttinghamshire Trust, and with a number of external partners on it, including the voluntary sector, Health Watch and others, as well as patients. And they examine the evidence to say, are they really convinced by that evidence that we have achieved what we've said we've achieved? And they will then sign off the evidence when they feel that it's reached that point, and that feeds through to those other governance groups that I've mentioned. So there is a lot of governance around this.
A follow on.
And indeed, Councillor Gurley.
Thanks, Chairman. So I get that now. That's made it clear as mud.
Apologies.
So all of those that's doing all this, looking at the service and trying to improve the service and scrutinising, it could only come up with 2 recommendations, according to this report. Yeah, one of them is to do the service quicker, and the other one is to improve responsiveness to immediate needs. So in fact, that's the same, isn't it? Responsiveness and moving quicker. So actually all that has come up with one recommendation, that you need to do everything quicker.
So no,
that's according to this report.
Just to clarify, those recommendations were from the CQC, which is none of those things that I've mentioned before that are separate. That was the CQC that came in and did that section 48 review that I mentioned at the beginning, and that's what then led to us setting up all the governance to ensure that we're delivering those CQC recommendations.
So the CQC have read the reports of the boards, I take it, and all those that you mentioned.
No.
Did you come up with those recommendations?
No, the CQC came first. So the CQC report came in February and March last year,
right.
2024. They delivered their section 48 report with those recommendations. And then all of that other governance that I've talked about is what's overseeing the delivery of those
recommendations. Try and improve those 2 things.
Yeah.
Right, okay, thank you. I've got more, but there's obviously other people who want to.
Not a problem. Councillor Upton.
Thank you, Chairman. I echo to a large degree what Councillor Girling said. A little bit of context. I'm a chartered building surveyor. Health is not my expertise, but I'm willing to learn. I read this report 3 times, and the outcome really was, from my perspective, and I hope I get better with time, it's packed with acronyms that I don't know and are not familiar to me, but I get it. They're obviously familiar to people that work in this sector, and why not? But I always try and campaign for plain English for people like me that's coming into this area of work, if you like, with very little knowledge. And it's absolutely crammed, as my colleague Councillor Girling says, with scrutiny and governance and this committee and that committee. And it seems that, from my perspective at the moment, I've only been to 1 meeting of health in my life. But when I was put on the fire authority, I rapidly got up to speed, because their reports, although it was another world to me, I rapidly got up to speed. I've read this 3 times and the next report. I find it incredibly hard. I hope I can improve, but it seems incredibly complicated. I know the NHS is big, it's a huge organisation, and this is a small part of it, but it lost me after 3 readings. I was more confused having read it than when I started out. So I can't contribute much today. I'll ask a few basic questions, but the rest of it's gone way over my head because of acronyms, detail, huge bureaucracy, in my opinion. I may be wrong.
I can only apologise. We
don't apologise. It's the world you inhabit.
Well, it is. Right, we did try and spell out the acronyms, but you are absolutely right. I often feel I've moved sectors several times in my career, and I often feel when you move to a different sector, you have to learn a different language. Yeah. The NHS probably is on another level with that, and we tried to make it as understandable as possible. We would take that feedback, and certainly next time we come, we will try and make our reports clearer.
I just wanted to add to that as well. I think that sets us a really important challenge as well, because to be held account by the public and our patients and communities if we are describing the language as complex and difficult to understand. How do we expect our communities to do that? So I think that acknowledging the feedback around the content of our report going forward, I think there is a really clear action there for us around how we ensure that we are articulating in a way that people can understand, not just for the purposes of scrutiny, but also we should be held account by the public, our communities, our partners. And if we're talking a different language that people don't understand, that's not going to help us improve what we need to do. So I actually think that's a really helpful kind of articulate for us to take away.
Absolutely.
Councillor Barlow, do you want to?
Yes, thank you. Thank you, Chair. Obviously, you've got the recruitment of 20 new crisis staff already achieved since June. Obviously, given the national shortages, how confident are you about filling all the posts by Q4 25-26?
Yeah, we are confident. I think what we're seeing is we have 4 posts left to fill. We're just in the process of onboarding those posts. So we have, I believe, 5 people starting in November. We have around 9 starting in January, and then we're out again to recruit for Q4. I think it's important because although the stepped approach wasn't what we wanted, we would have liked to have recruited everybody straight away. We have had to work to make sure that we've got the right people in post, obviously. There is a lot of training involved, as you can imagine, as well, and particularly around technology. So actually it does give us an opportunity to, by Q4, make sure that we've got everybody we need, but well trained and able to do that job well and safely as well. But we're nearly there. We're confident that we'll get the last few people in before and trained before the end of Q4.
Follow up to that, Councillor Barlow?
Yeah, so obviously because stuff whatever, and obviously given waiting times, what is the longest wait currently, and how do the waits in Nottinghamshire compare nationally?
So I can answer that as well. The longest wait changes, you know, on a daily basis. We have live access to that data, so we do have people that are looking at that data all the time. I looked at the national data last week at the request of the ICB. It's really difficult to place ourselves in terms of the national picture because everyone's operating model is different. What you have in Nottingham is everything coming through to one place. You have in other areas, you know, that you only have 111.2 coming through. We're about the middle of the pack in terms of the 95% centile, which is better than I expected, given the recruitment problems that, well, not recruitment, the actual number of staff that we had. But it's difficult in terms of a patient experience perspective. It's difficult outside of the data. It's difficult to say what that will be like because, like I said, the operating models are very, very different. You have 2 very distinct operating models, but actually everything in between that as well. But in terms of the 95 percentile hitting the KPI that NHS England give us, we sit almost bang in the middle, 50%.
Thank you. Thank you, Chair.
It's about that, if I could, Jim.
I was going to move on to Councillor Rich, but if you've got a very quick point,
All it is if you find it difficult to measure, how are you going to assess yourself on improvement?
So I think we can measure ourselves. I think measuring it against others is the difficulty. So what we know is that we still have a higher than we want abandoned call rate. We know that that's sitting at about 30% at the moment. Our aim is to get that down to the national KPI, which is 2%. So with the recruitment, we'll hold ourselves to account to that. I think what is difficult is holding ourselves to account in terms of the national picture, as in organisation against organisation.
Thank you. Thanks, Chairman.
Councillor Rich.
Right, I'm going to start this out dark. I'm going to be point of Girling and Upton. I'm going to keep it point. Basically, what's the point of this bureaucracy? What's so much about all this stuff that needs to put in place? What's it all about? I mean, at the end of the day, I'm looking for this. He's made his point. You know, it's all over his head. I mean, at the minute, we need to get buy for money, the NHS itself. And at the minute, I'm seeing all this bureaucracy that we don't need. So can we just go through something more straightforward, more simple, get to the point, instead of just going off and creating just massive amounts of bureaucracy for no reason at all? Can't we? Have we thought about scrapping half of the stuff, and starting from scratch and start from the base ground up instead of having this extra bureaucracy after extra bureaucracy. I don't get it.
Shall I take that?
Absolutely,
So I understand, and believe you me, working in the system, sometimes it can be very difficult to navigate, but the bureaucracy is not entirely of Notts Healthcare's making. The bureaucracy is also around the being held to account nationally and regionally and locally by different parts of the NHS and also the CQC. And that is partly a way in which the NHS is structured, because it does have those local, regional and national layers. And each of those, Notts Healthcare is in something called National Oversight Framework Segment 4, which is a very clunky way of calling it. I think I would call it special measures, and I think that's what most people would recognise it as being. And as one of the organisations, there's probably about a dozen in the country that are in that category. We are subject to a great deal more oversight, scrutiny, and bureaucracy, as you say, than most other trusts would be. And so a lot of what we've described is not of our making, it is as a consequence of the position we find ourselves in.
I do wonder, sorry, Chair, just to add in there as well, I just wanted to pick up on the point that I think was at the end of the question in relation to doing things differently and actually not always doing what we've always done. The improvement programme, taking out the context that John's described in terms of governance, actually the improvement programme is very focused on being at the ground, working together with our practitioners, our patients, our partners to do things differently, because we recognise that what the event led us to here means that we need to do things differently. The way we respond to needs to be done differently to ensure that we provide sustainable care for the future. We need to think differently. So I just wanted to kind of come in there to say that that improvement programme is in the context of what you've described and Jan's talked about, but actually there is a real focus on not just trying to improve and continue what we've always done, actually really thinking differently about what those clinical models of care look like. And that's what we're starting to embed crisis as an example of that, and some of the work that's going on in community as well to provide that assurance.
No problem on that question.
I was going to bring Councillor Thatcher in, but if it's very specific,
So why can't you make it simpler? Not making it better, simpler. That's what I'm asking.
I think that's part.
And that's what I want to point out, because it's great to have it all change and new and all this stuff, but we need to keep it simple. Because at the end of the day, people look and think, what's this all about? Well, I've got this, or what's this all about? Well, do you know what I mean? So that's where I need to say, just make it simple, and then everybody understands and they're on the same ground as everybody else, if that makes sense.
And I absolutely take that on board. And actually, part of what we are trying to do is certainly from the point of view of the people who use our services is to make that access and that route through services as simple as possible. And also for colleagues such as primary care colleagues, because we know that it can be confusing also for primary care colleagues referring into our service. So that is absolutely the aim, is to make that that simplicity for the people who use our services. It's in terms of our own internal bureaucracy, we also want to keep that as simple as possible and make sure that the people who are doing the job, people like Jane, who are really day by day improving services, are not having to spend all their time in dealing with that governance.
Councillor Thatcher.
So the report states that demand calls into the crisis access line have been high in the balance of capacity with demand. How much higher has the demand been expected, and how has that impacted on performance?
So I think, as colleague there described, there was a definite mismatch, and I think from the top of my head, it's about 3 times more in terms of the staff that we had and the staff that we need. Again, a lot of that comes down to the operating model, and we are making some changes to that. Once we get the first lot of new staff in, we're making a change, because actually Notts Healthcare, in terms of the calls that come into their crisis line, is the largest, the busiest in the country. That's not to say that there's more people in crisis in Nottinghamshire. Actually, it's the way that the system's been set up, so everything funnels through that one door. We're going to make some changes, and it's particularly pleasing. I've seen some correspondence with GP colleagues this week. We're going to make some changes about how they access the service that will make it quicker, that will mean they don't have to go through screening. And there's a few different call pathways that we're going to change that will mean that number will come down. You know, it's not about the number of people that need the service. It's about how we get them to the right place in the simplest way possible, I think, as Joel was describing. So we've got professional lines that we're going to enact. We just need that first lot of trained recruited staff in to do that. That'll make it much easier for, I suppose, partners, all partners, not just GP colleagues, to access a conversation with a crisis nurse. It has been difficult. It means that our abandoned calls are higher than we would like. That's one of the measures that we look at. Actually, we want everybody to be able to get through to somebody if they feel the need to. We manage that through the Safe Now programme that Joe spoke of. That's one of our challenges, to get that down to an acceptable level. Everyone can wait, but accepting that actually if you're in a crisis service and you've got a really long wait, that's not okay. Nobody gets cut off, but because of the long waits, inevitably some people don't stay on the line. So that is one of the things that on a weekly basis, and we can see it daily, but on a weekly basis we're challenged, we're scrutinised by ICB colleagues as well on a weekly basis around that.
Have you got follow?
Yeah, so is that part of why it says later that you've not yet been able to offer an all-age service? Is that just
it's linked.
So when you say all-age service, what does that look like? What does that actually mean?
So it's incorporating children's services as well. So I suppose the spirit of the model nationally is that you would have an all-age service. You would then go out to specialty, but actually that anyone that pressed 111 and selected option 2 would come through to one place and get put through to where they are. So it's the children's part of that we need those extra staff in to be able to fully do that.
I think probably just to build upon that as well, in terms of whilst the current model that we're referring to today isn't all age, to assurances of committee that there is absolutely a model that serves our children and young people and their families. That only is separate. We see the value and opportunity of enhancing that offer through the crisis model that Jane's referred to. But I do want to be clear that the same principles do apply within our CAMS crisis services, and what we recognise is some of the pressures and challenges that we've experienced in some of our adult pathways have not been identified by the CQC within our children, young people and families services. So whilst that is our ambition, I do want to provide assurances to committee today that our clinical offer is in that space and will continue to be in that space until we can reach our ambition in all age service.
Councillor Wright.
Thank you. Is within our county in Nottinghamshire, is there any particular areas that you think need more support, and what solutions would we need to do that fix that area?
So shall I start, and then Jane and Joe do come in. So within Nottinghamshire, I think 8 of our 11 teams are Nottinghamshire based teams. I think the other 3 are city teams, I think, if I've got that right, in terms of local mental health teams. And I think we have seen some variations in how those teams have been able to perform. And some of that is down to some teams have had higher than average levels of sickness. Some teams have struggled to recruit, for instance, psychologists. And that's part of the work that we've been doing to try and make sure that we've got that consistency across all of the teams. I wouldn't like to say at this point in time there is one particular geography within Nottinghamshire that is problematic, because I think it does shift from time to time. But what we are determined to do is to ensure that wherever you live in Nottinghamshire, you will have a consistency of service. In terms of the support that we need, I think moving forward, and this is kind of true of all of us working together, local authorities and health, I think developing how we work in neighbourhoods by working together is going to be absolutely crucial. And that's something that we're very, very keen to ensure that we're very much part of with the whole system, thinking about how do we ensure that our public services are joined up in those neighbourhoods to serve those communities. Don't know if you want to add anything, Joe.
I think so. Just to build upon the question a little bit in terms of, so as part of the improvement programme, we're very focused on developing and designing those future pathways to be focused on the needs of the community. So whilst we absolutely want to see consistency, high quality patient safety, patient experience in every area, what we recognise is that we need to flex our resource and our response to the community. So as part of that work, we are very focused on looking at what is the need within that locality and that community, both from a qualitative and quantitative data and intelligence perspective, but also from the feedback we get from communities, what our voluntary sector organisations are saying, what our partners are saying within that particular area, then to build and design our structures in terms of how we deliver our care around and wrap around the community, which links to the neighbourhood model. So what I don't think we'd ever be here sitting and saying is actually the structure or the number of people or the number of clinicians in one area will be the exact same in another part of the county, because that will flex and differ depending upon the level of need that they are responding to. So we know that each team has varying levels of need, and there will be varying levels of acuity and complexity based upon that community environment. So each of our teams are modelled on what we refer to as a safer staffing model that really responds to that. So from our perspective, I don't think there's any area that we particularly identify that we haven't got that support. But what I want to kind of articulate today is that that's where the differences will come in terms of numbers of staffers, numbers of medics, numbers of colleagues that are involved in that particular locality.
Okay, so the data you've got doesn't show an area that needs, or a community that shows it needs a little bit, because surely all over Nottinghamshire there's going to be challenges. So you haven't got that information then?
No. So to be clear,
I'd say Ashfield is struggling, but that area is doing fantastic. You haven't got that data.
So in terms of the data around the community, we've absolutely got that in terms of, so what we recognise is parts of Bassett Law, parts of Ashfield, Mansfield, are those greater level of need. And when you overlay that again with the county's data and intelligence, that aligns in terms of where we are. So if we were looking at levels of need, we're absolutely aware, but our resource is currently adjusted to that locality.
That's what I asked.
Yeah.
Thank you.
Sorry.
No, sorry. We didn't. Yeah. We misunderstood what you were asking.
So just tell me. He's not trying to catch you out.
Yeah. No, absolutely.
I know those areas.
Yeah.
Absolutely.
What we want to see is we want a little bit of support and put our arms around it a little bit.
Absolutely.
You agree?
Yeah. No, totally.
No,
and what I mean, we didn't articulate it well enough, but that's absolutely right.
Stop using the word articulate.
Yeah, you're right.
Because you probably said it about 15 times already.
We need to say it clearly, and what we need to say clearly is that we do understand that there are different needs and different.
We've got a champion there,
and we've
those got to be champion. Yeah. Okay, thank you.
Councillor Upton, did you want to come back in?
Yes, thank you, Chairman. If I could refer you to item section 3, crisis updates, which I think is all about people with a mental health crisis, or they perceive they have one. And those 2 bullet points allegedly are recommendations, I presume, lifted exactly from the section 48 report. Bullet point 1 talks about providing safe care for the person that perceives to have a mental health issue, the families and the public at large, and the risk of harm, etc., etc. And says that they should be able to get to the service without delay. But bullet point 2, I find incredible whoever wrote that, quote, improve their responsiveness to people's immediate needs by ensuring calls to the crisis line are answered. Wow, yeah, I would hope they are answered. And that 4-hour and 24-hour targets, whatever they are, why there's a 4-hour and 24-hour, are met more often and consistently. That's pretty woolly, isn't it? Met more often and consistently. Meaningless to me. I mean, I don't know, perhaps somebody can answer. What is felt to be a reasonable wait then before you abandon your call? I phone insurance services and other organisations. I wait for about 20 minutes maximum. After about 20, 25 minutes, I think, oh, heck, I'll just put the phone and I give up. But sometimes they give you a message saying, you know, service is busy on number 39 in the queue and Greensleeve's place for about a quarter of an hour. And I sit there. But I mean, I've no conception from this report, unless I've missed it. What do you feel is a reasonable time for a person with allegedly a mental health crisis wants to speak to somebody in the health sector, but after, I don't know, 15, 20, half an hour, gives up? That's the worry for me. And I don't know. What is the 4-hour and the 24-hour target all about? I'm sorry to do that.
Yeah,
You go on, Jane.
I'm happy to take that question. In terms of the time for the crisis line, the national target is 2 minutes.
2 minutes?
2 minutes.
Wow.
And just to put some context around that, that is just for the phone to be answered, and then you would get through to someone who would screen your call. So there are processes that sit behind that. But the national target is 2 minutes for that call to be answered. The 4-hour and 24-hour targets were around if you've spoken to someone and there's been a triage completed. So we talk to you, we realise that you need to be seen face to face, you need an assessment. The two targets that we are given nationally are we either need to respond, and it's in terms of risk, we either need to respond within 4 hours or within 24 hours. Those targets are to give parity with physical health. That's how they came about. So the premise or the spirit of the target is that if you went to an emergency department, when these targets were set up, that's what they would be working to. If you went for physical health, you should be seen within 4 hours. Be a significant breach if you weren't seen within 24 hours, and that would, you'd be triaged on need. Those targets were applied to crisis teams as well to try and give parity to people with mental health problems. More often and consistently, there is no national target for how many people we should see within 4 hours. It says that if you think somebody should be seen within 4 hours, you should see everybody within 4 hours. The same with 24 hours. If we think 24 hours is reasonable, we should see everybody that we rate within that. I suppose what we do is we monitor that on a weekly basis via Safe Now. So it does go up and down, as you can imagine. But actually, the aim at the moment with ICB colleagues and internally, we work to an 80% and a 90% target for those. 80% for 24 hours, 90% for 4 hours. Last week, and I will say this, it was a particularly good week. So I'm not saying this is always, but we hit 84% for our 4-hour target. We have had weeks where we haven't hit that, depending on what comes through. But I suppose that's where the targets come from, and we hold ourselves to account weekly, and then through all of those governance processes that have been described, we're held to those targets.
So all calls are answered?
Not all calls are answered. We have an abandoned call percentage at the moment. They aren't all answered at the moment. People do put the phone down.
Thank you.
Councillor Gurley?
Yes, thank you, Chairman. The staff, I sort of thought that when I read the report, that oh, that's great, that's loads more staff out on the ground. But having heard you speaking now, I'm thinking they're answering the phone. Is that the sort of thing they're doing? So that begs the question then, because you said about training them, and it's all about the equipment. Mm-hmm. I'm assuming that they run the same sort of system as the ambulance service does. When there's a question, they have a sheet of paper there. If you say this, get to page 10, whatever. But that worries me a bit, because I would assume for people that's trying to triage, you need to have a basic level of understanding about what they're doing. I mean, I've just completed, and I'm not after a job. I'm just telling you. I've just completed a level 2 suicide and self-harm prevention course with the University of Coventry, and it's an eye-opener, absolute eye-opener. But it gives me an understanding then of when I'm talking to people, and there's trigger words, isn't there? And you hear the trigger words, you think, well, I need to investigate this a little bit more. is the intent to then get these 24 staff on those sorts of courses? So it's just a case of all they've got to basically be able to do is answer a telephone and read a piece of paper in front of them.
I wonder if it might be helpful if I describe what happens when somebody rings. That might help. We have two processes. We have screening, which are what these new staff will do. That's really quite basic. That's to make sure that you get through to the right place. So if you rang, I would ask you maybe 4 or 5 questions. I would make a determination if you need to speak to a qualified member of staff, or if you're ringing for the phone number for an LMHT, or you want to speak to a GP, a community team. Sorry, local mental health team.
Okay.
So we have lots of people that come through that line that don't need to speak to a nurse. So they'll screen the call, and that's where the 2 minutes comes from. It's the 2 minutes to get to that screening. If the screening is completed and they need to speak to a nurse, it gets transferred to a nurse who uses, we don't have an algorithm like 111 as solidly as 111. It's far more nuanced than that. But what we do use is the UK triage tool that's used across the country. So it's a triage tool, particularly for mental health conditions, but they're all qualified members of staff that will do that. So I suppose we're not expecting the new staff that come in. It's a very basic screening that they'll do.
Can I follow on call from that? Thank the question. Sorry. So that's great. I understand that now, and it's good that you're actually getting those people in to answer the call, because any abandoned call is a bad. Yeah. Because they're probably in more crisis than the ones that hang on. Yeah. In fairness. But one of the things I've learned over my time working with people with mental health issues, say working with as a volunteer in a trustee in a charity that looks after veterans and seeing veterans with mental health issues, is not all mental health patients require a psychologist, right? So I myself saw a therapist for about 3 years. It took a long time for me to stop being a prat and being a normal human being again. But it took a long time, but a patient I paid for. Yeah, and I recognise that actually therapists have a really good based thing to be within the system. Can you tell me, do we outsource that? Because I know there's lots of mental health sort of therapists around that are private, yeah, that we could be using to speed up the process of somebody getting an access to see somebody. And just put this into context if I can, Chairman. I had a young lad that'd been through the NHS mental health system, couldn't get on with people he was being put in front of, was a very angry young man at risk. And I introduced him to the therapist that I was using. And he said, well, it'll be rough. So I said, well, just go and see. Yeah, and as a result of that, he went and he kept going. And the charity I'm in, we paid for the first six appointments, and then did an assessment on them, can they afford to pay, and if not, we'll subsidise. And then they went on. And it really got him out of it, because they just have a different approach, and it's not the establishment that's doing it. So I'd like to think that we outsource some of our care to people like that, because they do work. And if we've got waiting lists, because that's the biggest thing, you can go through the triage, they can get sort of answers within 2 minutes, they can be put onto the right people to triage them. It then says they need to see this particular type of person. And then the biggest thing about that after that is the length of time it takes to then actually see that. And we're talking in some cases years, aren't we? And that is, you know, if you're in a mental health crisis, a year is far too long, and that's why we see so many suicides, particularly amongst veterans, yeah, that have gone through the system, feel like they've been abandoned, and then take the ultimate action and kill themselves. So that's the bit for me that really needs to be drilled down on. You know, why are we taking that such length of time to get somebody in front of somewhere, to get the system, get the mental health care being provided? That to me is where the focus should be. But
I suppose just for a little bit of context, if somebody needs crisis services, they would get it there and then. There is no waiting list for crisis services. I think it comes after that if it's longer term therapy that somebody needs. which would be within the community that you might see the waits, but I don't know if anybody's.
Yeah, I think that's absolutely right, Jane. It isn't the crisis services where there would be those long waits. The waits in local mental health teams are too long. Your point about outsourcing is a very interesting one. We do have some particular partnerships. So, for instance, we partner with Help for Heroes. We do a lot of work in terms of veterans with them to ensure that we have services that are tailored to particular needs of particular population groups. But I think this pathway redesign work that we're doing, part of what we're trying to do there is to think not just about what do we deliver ourselves, but what does the community need and who's best placed to deliver it, and that includes potentially outsourcing, working with voluntary sector, etc. Joe, you want to add to that?
I think we need to be really clear. Jan's talked about partnerships. We don't currently outsource as a general kind of approach. There are exceptions for that. The scenario you described around young people, for example, through the education, health and care plans linked to the SEND agenda, schools and other settings do outsource and commission. I think it's something we need to take away, but in answer to the question, no, that's not a general rule.
You're using put into context. So I'll put some into context then. Sorry, it's really important.
Yeah, and can you make it succinct?
Yes, it will be.
Please, because I've got other contributors to bring in.
I'd have finished by now, to be fair. Put it into context, right? You see them in the crisis, builds their hopeful that they're going to get some support, and then there's the big long wait. Yeah. And that actually puts them in a worse position than they were when they first contacted you. I think we need to understand that. Thank you, Chair.
Councillor Barlow?
Oh yes, obviously I'm looking at the patient feedback, and obviously there's key concerns around sort of suicide prevention, access to services and continuity of care. How are service users genuinely shaping outcomes rather than being consulted after decisions?
I think that's a really key point, and I'll ask Jane to talk about it from a crisis point of view. From a local mental health, the pathway work that we've described, we're working with an organisation called Partners in Mind, who are all people with lived experience, and they have been incredibly powerful in describing the issues and the concerns and some of the barriers that they have encountered in their own journeys, and in helping us then to be part of that redesign in shaping it. And we also have our own patient, carer and family reference group, which is full of people who either have experienced themselves or who have had family members or people they've cared for with experience, who are also part of that labyrinthine governance process that we described, but they are heavily involved. And at the last event we had in Mansfield, shaping the future of how our pathways, I think we had about, out of an audience of about 50, we had about a fifth of those were people with lived experience really involved in the discussions about shaping how we go forward.
I was just also going to add there, we've also established youth impact boards. The youth impact board has a focus on our children's services, but it also includes young adults between the age of 19 and 25. The youth impact board have actually established themselves and have identified their own priorities to work with the trust on, which they are leading, and we're working together with them on progressing them forward. So it's very much led by the young people and the young adults that are part of that youth impact board.
Yeah, for crisis we have a co-production group. So we have a group of patients and carers that are part of every decision. So I think, you know, when we were talking about professional lines, or when we're talking about even things that we see as simple about what does a whole message sound. I think we heard about green slates, you know, that kind of decision. They're all in the conversation. They are genuinely helping shaping what services look like. We also have identified patients and carers in our working groups. So when we're looking at quality, we're looking at our operational pathways, you know, how do you get into crisis and navigate things. We have people sitting in those working groups, or identified for some of them. They're not there yet, but identified for a couple of those working groups as an equal partner at the table. How can we make it work, and what does it need to look like?
Councillor Wright.
Thank you, Chair. Now we identified those areas of Ashfield and Bassett or Mansfield. What's the What's the underlying issue there that why they are in that catchment of a challenge?
I think with mental health, one of the things that I've certainly learned in coming to work in a mental health trust is that there is a correlation between deprivation and mental health. There is a correlation between trauma and mental health, and I think it is therefore we see it in the city as well. There is greater need, generally speaking, being in broad brush terms, greater demand for mental health services in areas of higher deprivation. I don't know if Joe wants to add to that.
I think that's a fair reflection. I think the other challenge is that in those areas where we've identified generally the volume and demand coming into our services is significantly higher in particular wards of those areas, and actually to be able to respond to that in terms of that level of need is significantly difficult with the resources available. So I think with what Jan's articulated and then that resource challenge, that's the challenge we experience.
Yeah, it's a lot of people in the area of Ashfield, where I'm from, they feel a little bit forgotten. That's how they feel. That's what the emails I get in, communications. Are we going to really boost that area a little bit more, give it a little bit more attention?
So the work that we referred to earlier on around neighbourhoods, that the absolute intention is to really focus in on making sure our resources are in the right place. Ashfield's one of our priorities.
Back in 18 months' time, would the landscape look better for Ashfield, Bassett or Mansfield, you think? Are you confident in that?
I think we've got to work alongside that 10-year health plan, haven't we, in those neighbourhoods, and what that's going to look like strategically. But the premise of that is to get care back into those areas, isn't it? How it's going to look, I suppose, is we're still working towards.
And what it is, one of the things that I would say is that as a healthcare trust, we have teams based in all parts of Nottinghamshire. We have not just mental health teams, we have community health teams based in Ashfield. Our job is to make sure that those teams can operate as well as possible, working with other services as we take forward that neighbourhoods agenda, because I think part of the issue sometimes is that we work in silos, both within health and also with other partners. And one of the aims of neighbourhood working is to try and break down some of those silos so that we're working together for those communities and really pooling the resources that we're putting to those communities. But absolutely, we also understand the need, as Joe said, to flex the resource to where the areas of greatest need are.
Thank you.
And I suppose in direct response to the question, if in 18 months' time, the impact is not there and it doesn't feel better, the plan, the national 10-year plan, the neighbourhood plan, the work that we're doing hasn't succeeded. It's because that's absolutely the trajectory of what we should be.
Yeah.
That needs to be the measure.
Thank you.
We'll bring in a second, Councillor Rich. I'm just going to ask a quick question myself. I've been quite reserved so far. So just in terms of talking about working with other agencies in the community, what is the trust actually doing to work with community groups, faith groups and volunteer organisations to probably give that more holistic approach to mental health rather than the overly medicalised side?
Absolutely. It's a great question. And for the last 2 years, I have been chairing a group that I brought together, particularly around the CVSs across the county and the city. We've called it a third sector commissioning group, which isn't exactly a great title, but I've had representatives, generally at chief exec level, from all of those CVSs coming together to understand how can we work together better. I don't think in the past we've always been great at how we commission the third sector, because I ran a third sector organisation myself for 5 years, and I understand that sometimes the statutory sector thinks that you can just give a short-term contract and expect the voluntary sector to dance on a sixpence and deliver, and it doesn't work like that. So we've been working at a compact, if you like, about how we work together. And we've made some really good strides on that. But what also we do is we work very much with the existing place-based partnerships that there are, and there are 4 of those at the moment, although Mid Notts and Bassett Law are working very much closely together, and then there's one for South Notts and one for the city, and all of those have the voluntary sector on well represented on them, and we have identified the need for us to really work through those more umbrella voluntary sector groups to get to some of the very, very small organisations that are doing amazing work in their communities. I had some fantastic presentations from some green social prescribing organisations. These are tiny little micro organisations, often run by 1 or 2 people, doing amazing work with people in their recovery, helping them, for instance, using green open spaces or climbing as a way of helping recovery. And we need to build that far more into our pathways than we do at the moment. And that's why we've got the voluntary sector well embedded into those events that we were talking about in terms of how we do that pathway redesign. So I wouldn't say we're there yet. I think we absolutely understand the need for us to get there.
Yeah, the reason I ask that is I often find that sort of healthcare and things like that overthink things.
I agree.
A lot of the time. I'm a champion of grassroots sport, so I've run cricket clubs, I've run football clubs, paddle sport clubs. I know that Councillor Dodd has been involved in grassroots clubs. I run a veteran support group as well in my local division, and we're never contacted or requested, to get in that conversation. And sometimes it's that very grassroots level where just people in the community coming together is actually more effective than having to bring it into a healthcare setting to then re-branch that back out. And it's just understanding how the trust could potentially at a very low level, direct people towards those things, because I've seen the positive power of grassroots organisations rather than medicalising anything.
Yeah, totally agree. And I don't know if councillors are aware of the website that's called Not Alone, which is a website that has been sponsored by the local authorities and the ICB. I think it's a very well set out website that signposts people who are experiencing mental health issues and also professionals to not just those statutory services, but also to a range of voluntary services that there are. I don't think we're anywhere near where we need to be yet with what you described. I completely understand what you're talking about, the power of sport. There are many fantastic things that go on at grassroots level, and our teams are connected to them in piecemeal fashion, but what we haven't got is a really great sort of underpinning structure to make that happen better.
And I think I would absolutely agree. So I don't think we are where we need to be in this space. And we know that, so I come from a children's background. I absolutely know that children and young people, for example, that have been referred into a statutory service have made at times more progress by joining the Scouts or another uniform group or going to a sports club. And actually that connectivity, I think this does link back to that neighbourhood conversation, because if we get it right in that neighbourhood and place, we then use the assets from the whole community to drive forward the outcomes that we want. And I think what we are very much saying here today is saying we're not where we want to be, but we're also not the best people as an organisation or to respond to need. We need to do that together. So I really acknowledge and kind of reflect that, and that's why we're keen to develop that. And that when we talked about support earlier on, I think that's probably one of the areas that we're keen to work, really keen to work with people to try and develop and drive that forward.
Councillor Rich.
So for knowingly, I want to know about therapy and how long it's going to take, and how long for the waiting times and how long is it take for the therapy that they need in that regards of their mental health itself.
So I think that, I don't know, because Jane, it's not so much yours, is it, from the Price's point of view? This is more local mental health teams. And I think at the moment, those waiting times will vary. They will vary from team to team, and they will vary from patient to patient. But overall, this is part of what we're trying to do to try and get more consistency across those waiting times. I don't know, Joe, if you can give any further detail on that.
So we've currently, so it does vary from individual need and presenting need and pathway, so it would be difficult to give an overall. We do have patients waiting over 18 weeks to access for that therapy, and that can range depending. Our absolute aim currently is to bring that below 18 weeks and then continue to reduce that as we go forward with the improvement programme. It does vary massively though, so we do have some waits where the variance is between 7 and 9 weeks, and then between 18 and 24. So there is real inconsistency across the patch in terms of the delivery of that, and that's why there's a real focus in the improvement programme on support whilst waiting, because we recognise those waiting lists are not where we want them to be.
Is it a brief point?
Very brief. When you did your presentation, you said part of the criticism of your service was you didn't know how many people were requesting mental health services and what the waiting times was. And it still seems like you don't know how many they are and what the waiting time is. I thought that's supposed to be part of your programme.
So,
go on, Joe.
Sorry, to be absolutely clarity, we're more than happy to send back the data for each individual pathway. There are significant volumes of pathways that are on across our whole range of services, from children's services through to adults, through to older people's services. So for absolute assurance, the panel, if I go back, I can absolutely see that in terms of what the weights are and what the weight is for every single patient, and we can provide that in written form. What I'm unable to do today is roll it off the tongue, because there are so many different pathways and different indicators.
Well, if there's no more requests for contribution, I'll just ask a couple more questions and then I'll sum up if that's okay. So one thing that sticks out for me in your report with regards to patient feedback, and it's some of the bullet points there, and the one that sticks out for me is the feedback around moving from a medicalised approach to a holistic approach for personalised care. So I just really wanting to understand how the trust is sort of looking to make that transition from holistic and therapeutic from care, from more of the medicalised side of things.
I think that's probably goes back to the previous question about the involvement of patients themselves and the involvement of community groups, because I think in the past, I think maybe we haven't operated in partnership as well as we could have done, and I think that's one of the key lessons that we've learned, is that we must do far more to work with those stakeholders to understand when it is appropriate for us to provide a service and when it's appropriate for us not to. And I think that maybe in the past we haven't done that as much as we should have done. So it is very much part of that pathway redesign.
I seem to have inspired another question. Just pass over to Councillor.
That's right. The chairman's just brought something to my mind right now. Along the side of this therapeutic treatment, we also thought about alternative medicine. Where's the place of that in helping and supporting patients in this space? Do we have any platform for such treatments to come in and help and get people better?
So we've more been focused on the kind of social prescribing side of it rather than the alternative medicine side. But I don't know if Jane or...
Yeah, I think, it comes back to the previous point as well. I think it's our approach to care planning, which we're taking a very different approach. I think it's very much about what's important to you, what will get you well, other than us going, we know what will get you well and we know what this needs to look like. So I think there's a number of things that will be brought into that very much more personalised care planning. So if somebody is looking for alternative, therapy, that would come through that care plan, and we would obviously signpost to the most appropriate place. I think it's very much about us getting alongside patients rather than that medical model. We know what will get you better, and we're working very hard on that personalised care approach.
Okay, thank you.
Right, I've just looked at the time, so I think it's probably best that I summarise now, because otherwise we'll just go on. So ultimately, there's been some really good points brought out by all the committee members, and some really good information provided by yourselves as well. So I really appreciate you attending this morning. Some key themes that came out, and the one that stuck out in my mind, I think, was I'm not going to say the word well articulated, but committee members did put it across well, was about clarity of language. And I don't know whether other committee members felt this, but I think we're the politicians and we spoke in a more straight and forthright manner than yourselves.
Fair enough.
And really we're not allowed, we're not after that. We're wanting to understand, for the electorate, what the service is doing. So I'd definitely sort of amplify that point and just say, you know, come back and speak plainly, please, because it is the electorate who are, you know, accessing these services. Another key theme was about collaboration and working at all levels, and really sort of understanding the need in certain areas. And for me, you know, I think collaboration is really important. And I think to some degree, we've lost that connection with the basic fabric of society. You know, you look at the 70s and every works had a sports club. I know I'm bang on about sports, but, you know, there was other groups and things like that. You know, you had brass bands and choirs and everything else, whereas now everyone sits in isolation and nobody goes to the pub anymore and things like that. I'm a fan of the pub, as you probably see. So, yeah, for me, I think there's a real piece there about how you champion that sort of you know, connection with the basic fabric of society, and you know, how we promote that as well. So I think it may be worth sort of getting a further update from you, you know, in the cycle of the work programme around sort of understanding areas of need, for the service, but also how you can work in a more joined up approach, and what you may need from ourselves as the local authority. So I'd be definitely interested in inviting you back for another session and speaking more plainly as well. And that was really it. You know, hopefully you got as much out of it as the committee did. So if it's okay with everyone else, and shout up if it's not. But I'd like now to move forward to the recommendations, and that is recommendation 1, and that the report be noted. So can I see all those in favour of the report being noted? Carried. And that number 2, that feedback of members on the pathway redesign for crisis and community mental health services be noted. See all those. Yeah, and that's carried as well. So like I say, I do thank you for attending this morning, and I would like to invite you back at some point and see the progress, you know, in relation to where you're at in your plan, but also the points that I raised there in summary as well. So thank you very much.
Thank you. The abandoned call rate percentages when you come back.
Yeah.
So it can be measured.
You can do that. Thank you.
Thank you.
Thank you very much.
Bye-bye.
For their own.
So we're just waiting for the ICB colleagues to come in, apparently outside. So
yeah.
Otherwise, you're correct. It will be a short meeting.
Tiny now. Have a smash of that.
Morning.
Morning.
How are you? Well.
Good, thank you.
Good. Is Andrea here as well? Or?
She's not very well.
Oh, right, okay.
It's just me, I'm afraid.
I'll just wait for Councillor Dodd. Thank you, fine.
We're just waiting for.
I'm not going to wait for him. I don't know how long he'll be, so I don't want to keep Gemma waiting. So. Okay, everyone. Councillor Adagoki's just gone for a comfort break, so I'll carry on anyway, because I don't want to delay Gemma. So the next item for consideration is a report from the Integrated Care Board in respect of preparations for the increased system pressures anticipated during the winter months of 2025-26. The ICB generates a winter plan each year, and members requested the report to provide a review of the learning and performance from last winter and plans for this winter. I would therefore like to welcome a representative of the ICB, Gemma Weissall.
Yeah.
Thank you. And you are the Deputy Chief Delivery Officer for NHS Nottingham and Nottinghamshire ICB. Lovely. Would you like to introduce the report?
Yes, no problem. So morning, everybody. My role in the system when it comes to winter planning is each of the organisations across health and care have their own internal winter plan of how they'll cope and respond with winter pressures. So it can be anything from increased numbers of people going into hospital to snow and cold weather to an IT outage. So we really try and capture everything. What I do then on behalf of the system is to bring that together so that actually we work across health and social care together to understand where are our pressure points over winter and how are we going to work together. So just to give you an overview summary, what we do is we track what happened last winter, what happened the winter before, what do we expect to happen this year, and how will we test that, and what actions will we embed and have in place. And we also look at what's happening in Australia. So we look at flu, we look at norovirus, and we say actually we have a trend curve that we manage year on year. So we look at what's happening and then we plan accordingly for what we think is going to hit us in the winter this year. So the good news for us is that the peak is currently tracking lower. So in the last 3 years, the peak is showing that it's lower, which is good. And we've built all of that scenario planning into our winter plan. In terms of very practically what we do, so I chair a group that meets fortnightly and we look at where are we at, what's happening. So actually September has been a particularly busy month. We have got numbers higher than we were expecting for a whole host of reasons. So the teams are actively responding today to those pressures and we're bringing some of the winter planning earlier. I thought it might be helpful if we just go on to the next slide just to share some of the principles of our winter plan. So we're really conscious that there's a big focus this time of year on vaccinations. So how are we vaccinating all of our communities to the best possible effect? Obviously that helps us then later on into the winter. Communications is essential. So some of the lessons learned around winter is that some of the messages are really simple about staying well, staying warm, staying hydrated, looking after yourselves, looking after your neighbour, looking after your communities. And those are the things that we have to make sure each winter that we do to remind our population around their role in helping us as service providers over the winter. I'm very conscious of our frontline staff teams across health and social care who will be out in communities over the winter period. And also within the ICB and within all of our system partners, we actively monitor the data about what's happening day by day. Just onto the next slide. So I have to submit a system winter plan to NHS England. So that's 117 pages long. You're very welcome to read through that if you want. So we also have 62 metrics that we have to report daily, weekly and monthly. Say, are we on plan? Is everything where it needs to be? And it incorporates metrics from across the whole system. So everything from our ambulance response time to discharging from hospital back into communities and whether people are then being readmitted into hospital. And the idea is that once we look at that data, we look at it live every single day, that we can then put corrective action in place if any of the indicators are going off target. The next slide is just a summary then of what we learned last year. Just a couple of things to pull out, which I've mentioned around communications, vaccines, and making sure things like our care home staff are reminded around the simple interventions that work. So things like hydration and falls. So we've actively been working together with health and social care around supporting care homes ahead of the winter. The next slide just gives you a view of what's happening in the Southern Hemisphere. So we do track this every year and it does really help us to inform our winter plan around the levels and peaks. So although you won't be able to read that closely, so the pink line is 2022, the blue is 2023, light blue 24, and then dark blue is where it's tracking currently this year. So we use that each year to plan what level of beds we need in our acute hospitals and what we think might then happen in terms of demand elsewhere in the system. Just a couple more slides to share with you. So some of the key winter actions are summarised here, and this is every system partner has their role to play. So we have some additional beds opening at our acute hospitals. In terms of mental health services, I know they were here previously, but they have just opened some additional beds, which is already helping us with mental health demand. We have got some specialist geriatric advice, particularly from our acute services. So where we've got frail older people needing support in the community, we've got consultants in the hospital who are at the end of the phone and providing that advice. We work with our acutes all day, every day on hospital discharge to make sure that people are going out with the right packages of care, and also making sure that primary care are really resilient over winter. And then a final side is all system partners have got their own risks, and we have a collection of system risks. So making sure that our workforce are as well as they can be over winter. So particularly things like vaccinations, really, really key. We monitor and manage staff sickness really closely, because that's a key part of making sure that we are looking after our communities. And we need our staff in work to help us achieve that. We are a financially challenged system, so all system partners present risks around finance and the impact that finance has. Previously, we've had winter pots of money that we've been able to access, but unfortunately there isn't a pot of money this year, so we're trying our best to do what we can with the resources that we have over winter. So Chair, that's probably a summary of where we're up to. I know we submitted a report as well, but I thought helpful just to pull out some key points.
No, thank you, Joanne. Thank you for that introduction. And just before I open the discussion, and you weren't in the room earlier, I'm probably going to have to leave slightly early, probably while this discussion's ongoing. So I'll be passing over to Councillor Wright as my Vice Chair. So just didn't want you thinking I would be in the room.
No problem. No.
And leave it. I'll now open up the discussion to members. Councillor Rich.
So as there is no funding for the winter this year, which services will be cut or reduced to cope with the extra pressures?
We're not planning any cuts to services this winter, so we essentially are trying to maximise what we've got. So it's essentially doing better with what we've got.
Okay. Have you got a follow-up at all? Is that it? No. Councillor Girling.
Yeah, thank you. Having seen your winter care plan many times when I was chairman of Health Scrutiny, I've seen the improvements going along. Then the only thing that sort of concerns me about the report really is on page 26C, and it really concerns me that even now, after all this time, knowing the potential death toll that could come from a winter, that we're still having to encourage the primary care to take part. Well, I thought the old idea of primary care is to save lives. So that to me is quite disturbing and quite worrying, that we're still having to try and encourage. They should be fully engaged by now, fully engaged. And I think it's shocking that they're not, quite frankly. And I know you can't do anything about it, but I think it's something that as a Health Scrutiny Committee, we could highlight and actually sort of express our disdain on, because it's not acceptable that we're still having to encourage primary care to take part in this. It's wrong, and I think that could be the role of this committee as Health Scrutiny Committee to help encourage that. Really, I just felt it was really poor that we're still having to do it. Thank you, Chair.
Councillor Upton.
Thank you. From my personal experience, my local primary care has been quite positive. They hounded me with text messages about getting vaccinated for flu and COVID. I confess I wasn't aware that COVID was out there as much as I found out recently that it is. I wasn't going to bother with a COVID vaccination. I've had about 5 or 6 so far. Look now, it's gone away. Clearly hasn't. And so the primary care, with their relentless texting of me, I booked my flu and my COVID. I haven't gone down the RSV route, and that shows my age, does it not? But it asks the question, people asking me, why is RSV, which I'd never heard of till a year or so ago, ever, why is it restricted to age groups 75 to 79? I mean, if vaccination of RSV, COVID, influenza is seen as the reducing the demand on hospitalisation, then that's one question. And I think there's a disconnect. I think people tell me, and I want reassurance. Previous winters, has there not been this problem about people are considered well enough to be discharged from the hospital, but they, for want of a better word, bed block, create a jam because they can't leave the hospital to a suitable pathway, to quote your parents, as to where to go. Whether they've got their home adapted under disability grants or whatever, which I'm involved with on the Borough Council, and the government's put significant more money into, which I welcome. But that takes time, does it not, to build a wet room and adaptations in your home? So I get it, but I would have thought there's a halfway solution to that. You don't need to be in a general hospital, district hospital, if you're well enough to be discharged with all its costs and requirements. Can't you develop a halfway house, like a hostel or a hotel type of accommodation? It doesn't need all your medical backup. It just needs basic care and looking after until you can actually go home or wherever you go. Sorry, rambled a bit. But vaccination, RSV, and bed blocking issues.
So the eligibility for each vaccine is set nationally. So yeah, so unfortunately it is set by the government on who they're going to target for each of those individuals. So it's age 75 to 79 and pregnant women who are eligible for the RSV vaccine this year. So unfortunately, locally, we can't change that. Unfortunately, it is part of it is nationally set eligibility criteria. Just on hospital discharge, so we do work really hard as health and social care together on trying to get everybody home that can go home. So we work very much on a home first principle. So if somebody can go home with additional support, we try and mobilise that package of care as quickly as possible. If people can't and they do need a bed, then we do have beds available across the system. But I do take your point around what we want to do is ensure that there aren't delays, that people are either at home or in a bed. So we do track that daily across health and social care, because obviously people leaving hospital quite often have a health and social care need, like home adaptations, etc. So we try and work really hard together to make that as speedy as it possibly can. There are some delays, but we try and minimise them wherever we possibly can.
Councillor Thatcher.
So I've just signed up 2 of my children for the school immunisations benefits for the flu vaccination. They're not actually vaccinations, they have a nasal spray. I was wondering what the take-up is generally in Nottinghamshire for the school programme on that, you know.
So we've got an update on that at the Urgent and Emergency Care Board on the 7th of October. Normally we do really well, particularly in school-aged children, but I can provide you with the data for that, no problem. And we'll have an update in 2 weeks of the cohorts that have uptaken that vaccination already.
Just coming on from that, so I always sign up my children. I live in an area which I expect has got quite a high uptake, but there isn't loads of information that goes out to parents about it. You get sent like an email with a form in it. But there's no, like, I don't think it's very clear that it is a nasal spray for children, really. And I was wondering if there was have plans to do more to kind of tell parents what it is and why children need it.
Public health responsibility for providing that information. So they liaise directly with the education authority and push that information out to all school-age parents. So it's
Do you work with them on that? Or?
We do. So we've got a vaccination group who plan it every year, but they lead on the sort of technical information that goes out to schools. But I can certainly raise with health colleagues.
Yeah, I just think more people might uptake it if they knew that they could on and get actually judging.
Yeah, no, it's a really good point. It's a really good point from the parents' perspective.
I'll just jump in at that point. So that's actually something for, as I said, public health, and it's been raised through the Health and Wellbeing Board. So it is something that's being raised, but I will seek more information from them, because I know Councillor Doddy's very keen on this as well. Councillor Barlow.
Yeah, I mean, it's good that we've obviously got an early development of this year's winter plan. So obviously, with the risk of no extra funding, financial pressures across the NHS and potential risk of industrial action, what contingency plans are in place if industrial action happens during the peak winter?
So we're well tried and tested as a system with managing industrial action. So this time last year we had junior doctors who were on strike. So we have a very clear industrial action plan of how it's junior doctors in a hospital. We bring down the consultants from every specialty to operate in particularly the emergency department, which is where we've got a large number of junior doctors. So for each group of individuals, we have a contingency plan in place of what we would do if industrial action hits over winter. So that's tried and tested, and we have all of those in place.
Okay. And just to follow, and will elective recovery targets slip due to any winter escalation?
So currently our plan is to maintain elective over winter. We did that last year as a system. So we're currently planning to do exactly the same again this year and protect our elective capacity. Currently that is what the plan is saying. So pending any contingency planning and things happening, we want to maintain our elective performance over winter.
I think I'm just going to jump in quickly because I'm mindful I may have to leave fairly soon. So just very quickly, so the medical safer transfer patients, I reviewed the reports provided by each health trust. It's the audit reports, wasn't it? Annual audit reports, yeah. And in the Sherwood Forest report, I noted that in year, so not over winter, but in year, the medically safer transfer patients actually going first time was affected 46% of the time by available transport. So there was cancellations repeatedly because of availability of transport. So what's being done to review that in sort of a view of extra pressure over the winter period?
So we have a transport provider that we commission together as a system, and they are largely outpatient focused. So their main area is around outpatients. What we try and do is plan outpatients on discharges together so that we can take patients to the hospital that got their outpatient appointment and then potentially pick up somebody who needs a discharge to go home. We are actively looking at what else can we do this winter with the transport that we've got. And I think the challenge for Sherwood in particular is that they've got 2 transport providers. So what we're trying not to do is to book one and cancel the other, because that creates an inefficiency. But the teams are looking at how do we improve that process for winter so that we get transport right first time, because absolutely it's not good for the patient, and also then the person is then in a hospital bed when they could be at home. So we're actively working on that right now.
That's all right, thank you. Hi Gemma. This is a question I ask quite regularly, so people may be bored of me asking it, but geographically in Nottinghamshire, is there an area that's quite challenging, needs a little bit more support? Where would you say that is?
It's a good question. I think we know from our population health data that every community has its unique differences in terms of our population. I don't think there's one particular area in terms of winter. I think what we try and do is, so for example, on transport, where we've got rural areas, that can become a challenge for transporting people home to rural areas. Packages of care can be more tricky in rural areas than they are in more urban areas. But what we do with providers is try and make sure that we're ahead of that in terms of winter, so we know where those hotspots are and we plan for it. Just trying to think of I don't think there's anything winter specific that creates a challenge.
If we've got a map of Nottinghamshire, there's no areas that are going to be a little bit lower than others that are pattern for, because I know those areas. I just wondered if you knew them, or do you have data to show, or you don't have the data to show?
We've got a huge amount of data.
So that should then give me an indication of an area that needs a little bit more love during this time of year. If you got that area?
When you say a little bit more love,
caring, a bit more support, because it's not had so much. No?
He's trying to get you to say Ashfield.
What's wrong with Ashfield?
Nothing's wrong with Ashfield.
Good.
The winter might affect elderly people, which not necessarily will be in Ashfield.
Well, we'll save that for a different conversation.
I guess my responsibility is for the entire population, so we try and make sure that
sometimes there's going to be certain areas like Ashfield, Mansfield, Bassett Law, they do get a little bit left out. I'm responding to the information I get. I just wondered if you've got that data.
We've got a huge amount of population
So
health
does it give patterns of say neglected areas or that need a bit more support?
I don't think it's not in terms of winter. So in winter we look at what happens, how are our communities made up, what are the things that happen in terms of transport, snow planning, care packages, etc. Okay. They're the particular things for winter that we look for.
Okay. Not really what I was looking for, but okay.
I think we've pressed that correctly.
Thank you anyway.
It doesn't work on every topic, does it?
I'll just be very, I know there's another couple of contributors want to come back in, but I'm going to disappear after this. So you mentioned about greater challenges in the rural areas. They'll get bored of me, I'm sure. I do represent a rural division. So what key considerations are you looking at with regards to the rural challenge and what the winter plan delivers for that specifically?
So I think the two key areas that we've discussed at length are transport and care packages. So we make sure that we use all of the demand and capacity modelling to know roughly how many people in our rural communities will need care and will need transport over winter. So we try and build that into our plans to make sure that we cover for those eventualities. I think the challenge that we always have is snow. So we track closely with the Met Office what's happening with the weather, but unfortunately it is an art. So we've got snow plans in place, we've got travel disruption plans in place, and work closely with health and social care around how do we provide for care packages at home when there's snow on the ground, for example. So I think transport and care are the key things that we plan for over winter.
Okay, thank you. I am going to take my leave now, so I'm going to pass over to the Vice Chair. I've noted that Councillor Faccio and Councillor Barlow want to make further contributions. Okay. So that's there.
Thank you.
The agenda's there. So okay. Thank you much, everyone.
Thank you.
Thank you. Councillor Faccio, do you want to go?
So the report mentioned in a few different places about the importance of staff. So can you just elaborate a little bit more on what you do to kind of help keep staff well, keep morale up when the workload's heavy, and kind of generally look after them so that they can.
Yeah, so each organisation who employs frontline staff, so obviously as an ICB, we're not one of those, but each organisation has got a section on staff wellbeing. So that might be looking at shift patterns, particularly over the winter, to make sure that we don't have staff having burnout. They have, particularly within the acute trust, they have additional support for staff who might be working in the emergency department, and it's a particularly busy time. So each organisation has their own staff wellbeing process for winter that they have in place to support them and look after them throughout a particularly busy time.
Councillor Upton. question? Okay. Councillor Gurley.
Yeah, thank you, Chairman. So, seeing Ashfield is right next to a hospital, and I represent Newark, which is about the furthest away from the hospital you can get. It is obviously in winter, and the transport becomes a bit of a challenge. It takes about, to get to Kingsmill, it takes about 45 minutes on a good run. In the winter, that can be, it'd be quite extended quite substantially. So what extra love and care are you looking at giving us out in the sticks towards Newark and Sherwood area? And also, how does that impact? Because obviously the demographics of Newark and Sherwood actually has got quite a high percentage of elderly people in it, particularly in my division where I operate. So I would imagine then that's a higher number of care packages required in that area. So how do you balance that during the winter? So Newark gets some love.
So we have to do exactly that exercise for all of our communities. Yeah. And so, for example, with Sherwood Forest, we've worked through looking at the Newark UTC, looking at PC24 at the front door, and looking at the emergency department, and then looking at the back end of the hospital of those patients that are discharged back into their communities. And so exactly the same comment, I think, to Councillor Wright about we plan for care packages, transport to get people home and keep them safe and well over winter.
Thank you. That's what the answer was. Can I just add one more thing, Chairman? You say about transport. I used to be in transport, and it can be a right pain because of the problems I see that you have really is you'll have the times and dates of patients coming into the daycare centre, which is relatively simple to then put the transport to those people to get them there. Where the difficulty is when you're getting somebody discharged. Yeah, that's not always, oh, it's going to be tomorrow, because sometimes the doctor will come along and say, well, actually, no, I want them in another 24 hours and things like that. So maybe look at a sort of like I don't know, an on-call service. So yes, it would be an additional expense, but actually I think it will save you money if you have transport that's there at the hospital waiting for those discharges, rather than trying to coordinate it. Because I can imagine coordinating somebody coming in and somebody leaving at the same time, or even within the same couple of hours, would be an absolute nightmare. But so maybe, sometimes it's best to, you always do what you always done, you'll always get what you always got. Yeah, maybe try something a bit different.
I think we've tried lots of things with transport. I think the challenge is that not everybody is eligible for transport, and also it's very expensive. So we're trying to absolutely maximise those people that need transport to get home, and then to plan it in a way that doesn't cost a huge amount of money. But yeah, it is. Yeah. It is.
Thank you, Chairman.
Thank you. Obviously, there's lots of talk about bed blocking and etc. So obviously, and that must increase, I'm assuming, probably over the winter period. Are there any plans to increase things like convalescent home? I mean, I remember years ago, you'd leave hospital, you would go to a convalescent home, and obviously that then freed up the hospital bed. Is there any plans for anything like that going forward? So to either increase or
So we work on a home first principle. So we try and make sure that wherever people can go back into their own homes, that they do with wraparound support from health and social care. Where they do need a bed and a bedded facility, we have beds across the system that we provide for people, but we always try and work to get people back into their own home if at all possible. And we've got some fantastic provision from both health and social care in terms of monitoring people remotely and providing care at home. So that's our first port of call, because it's better for the person, and also then doesn't use a bed somewhere else in the system. But those people that need beds, we've got beds available that they can go into. So from an acute, they might go to a community bed before they go home. So we do have that, but we try and make sure that wherever possible, people can go home.
Your winter plan, I believe it's not available, not being shared, is that correct?
It can be.
It can be.
Yeah,
Can it be shared?
Yes, absolutely.
Yeah. We appreciate that.
Yeah, no, we wrote the report for committee only because that's what we thought that you wanted. But yes, you could absolutely share.
I would like to see it.
No problem.
Yeah, if you would do that, that'd be fantastic. Thank you. Chris?
We have been using clinicians now for a while in most GP clinics. I was just wondering, how long are we going to do that? And because these clinicians, I've come across a few of them myself, I've even taken my daughter to the GP, and one or two or three had also looked at that. But we found out that some of the outcome of that meeting was not actually what we expected. Now, how long are we going to continue to use these people who are not really trained doctors, but of course very good within the health system, to continue to care for people, via the GP practice and things like that? Is there a timeline to withdraw them, or that's just the pathway forward right now, using clinicians?
I don't know the answer to that. We'd have to look into that specific practice. So yeah, it's not something that I'm close to in terms of the detail of who in that practice you were in contact with.
Yeah, generally, within the NHS sector system, is that a practice that we're going to take forward using clinicians? Because I think the clinicians are all spread out in all GP clinics somewhere.
I don't know the details about the workforce in particular, so I think we'd have to take that and talk to primary care colleagues about that. I can do, yeah, no problem.
Okay. Give us a feedback next time, please.
Okay.
Yeah, thank you very much.
Okay, one question for me. What will be the effects of the IBC clustering on system resilience?
The ICB clustering?
Yeah.
So each of the areas has their own winter plan. So for this winter, we will operate a Nottingham and Nottinghamshire winter plan in the same way that we always have. So I am winter director for Nottingham and Nottinghamshire for this winter. So we'll do exactly the same as we've always done.
Okay, thank you. But what about later?
That's to be advised, I think, in the changes that are coming in the ICB. So for here and now, for this winter 25-26, we continue as normal.
Okay, thank you. Any further questions?
Yeah, I've just got a question around availability of medicines. Obviously, there's different types of supply chains used to bring different medicines into the country, manufactured within the country. If we have severe bad weather, that are going to be disrupted. So I'm just curious, do you carry higher levels of stock on certain types of medicines? So I'd use a diabetic as an example, who wouldn't be able to go for very many days without receiving their medication. Subsequent people with other ailments would probably be the same. So I'm just wondering now how you manage that.
So we have a medicines management team who look at supply and demand of medicines, and they also have supply disruption plans. So if there's any disruption to any supply of particular medicines, what would the backup plan be? And then with NHS England, that's then monitored regionally and nationally. So there are plans in place, but that's all managed through our medicines management. They look at stock availability and disruption.
Thank you.
So, obviously you've got vaccination rollout plans in place. Uptake's been patchy in some groups. What's been done to address the vaccine hesitancy in some areas?
So we've got, I think Councillor Upton said about particular text messaging. So what we have got is a really clear vaccination plan. And actually, if I send the slides to you, you'll be able to look through what we're doing. So we target particular cohorts of people to try and encourage them to have their vaccine, obviously through schools. We go out through parental consent for school-age children. We've got a roving team who will vaccinate people in care homes. So what we try and do is think of innovative ways to reach as many people as possible with vaccinations, and the detail of which is in the plan. You're very welcome to see that. And we have a group that oversee that together as a system. So public health are heavily involved in how we plan and administer vaccinations for the population, but we try and make sure that we plan for ways that gives us the best possible chance of people uptaking their vaccines.
Any further questions? Well done. Okay, thank you very much. I just want to summarise on a few things. Vaccinations are set nationally. We found that out today. Okay. Just want to update on children's flu spray stats. I think obviously what was brought up, a bit more information going out to parents would be, because I didn't, I mean, my children are older now, but I didn't know that at all, so that's quite good. Plans for industrial action. Obviously that's a concern for a lot of people. Snow plans, seeing that we're so high up here in the north. And yeah, I think that about covers it. Yeah, thank you very much.
All right, no problem.
We want to do some recommendations. So the feedback of the members on the preparations for winter pressures be noted, and that versions of the current winter plan can be circulated, please. So I appreciate that. Can we vote? Can we vote on that? Everybody? Okay. Thank you. Unanimous. Thank you. Thank you very much.
All right.
Remember to send your love to school.
Question is, no, exactly now.
I did it for 3 minutes. It's awful.
Okay. Thank you, everybody. Anyway, just a few matters to highlight in respect of the work programme. Work programme event was held on 9th of September to give members an opportunity to determine our health scrutiny priorities and compile the work programme for the coming year. These priorities are all ages, mental health services, autism-informed care, system integration. The draft schedule reflected in the appendix reflects the priorities selected by members. These dates are indicative, and the scope of the timing of items will be confirmed in due course. There is a member visit to the National Rehabilitation Centre in Loughborough, which has been rescheduled for Friday the 10th of October at 9:30 a.m. Please let Catherine know if you intend to join. Any going to discussions now? Any discussions, items on the work
Can
programme?
I suggest, Chairman, that you, I don't know if it's on, because I've not really looked at it, because I'm only a substitute, but
Okay.
On the winter plan, getting somebody in that's responsible for our primary care to pressure them on why we're having to encourage primary care to take part in the winter fuel, in the winter plan, because although, as Councillor Upton says, is primary care unit does it well. Mine does actually,
Yeah.
but if there are within the county that aren't, I think that's something that this committee can put pressure on to get them to do that. And then my only other point is when you next bring in about the mental health that we've just had this morning, is to make sure that they do bring in the percentages of abandoned calls, because I think that's really,
I think that's a good
really
point.
important.
Yeah.
And also a bit, I think was fobbed off a little bit in terms of when the questions were asked, and I can't remember who asked them, about where do we stand nationally and things like that, and they made some nonsense about, oh, they're all assessed differently. No, they're not. They're all assessed the same. Yeah, and we should have an understanding of what their level was now, for the next time they come, what the level is then. And only then can really, as a committee, we can assess whether there's real improvements or not. So I think we need to pressure them on making sure those stats come in. And to say that there's all these different pathways, it's an irrelevance, really.
Yeah.
It's like whatever those pathways are, whatever the access to them are, percentages can all get added together, which gives a percentage. I'm sure that's what all the others do.
Yeah.
So you get an overall percentage of how the service is performing. And I think that way it's easier to hold them to account than the way it was today.
Yeah, we'll request that kind of baseline data.
Yeah.
I know I'm not champion Ashfield all the time, but we need to know where areas geographically.
But I don't disagree with that, but we need to know as Nottinghamshire.
Yeah, it's Nottinghamshire.
Where's Nottinghamshire where we stand, and then look at the breakdown.
And then we're within Nottinghamshire.
Yeah, absolutely.
If it's your area, mine, wherever. With those areas, the county need that all over that support.
Yeah, I just think it'll give you a stronger position when you scrutinise them next.
So the work. Sorry,
got.
Councillor Rich, yeah.
Yeah, so completely out of the blue. Is it possible we have an extraordinary meeting about endometriosis? I've had spoken with John Doddy, he was up for it, and wants to discuss about the conditions that affects women in this regards, and see where we'll go from there.
It's in for the next meeting.
Is it in the next meeting?
November.
4th November.
Oh, sorry, 11th of November.
Yeah. 11th of November.
Yeah.
Okay, no worries.
That one's there. Okay.
Thank you.
Any further discussions or any thoughts?
Can I just go forward with the work programme? So obviously access to GP and dental appointments is only to be scheduled. Surely that should be a high priority, because that is a major concern, I think, in all our communities. It's one of the biggest questions we always ask, whether or not that could be. And obviously with the risk of health watch being decommissioned nationally, are there any plans locally to ensure patients' voices are still heard?
Sure, I'll take this one.
Okay.
So thank you, Councillor Barlow. So you're absolutely right. Dental is a big priority. Members raised it at the work programming session. It was really important to members. So that's why it's on as a to be scheduled. We need to look at what aspect of the dental service can be improved by scrutiny before we take members' time from this committee and put it on dental. So that's work that I'll be doing. I'll be making sure that if we do put it on the work program, it's because by looking at it and bringing in the people to talk to, members will be able to make a difference to how that's being delivered in Nottinghamshire. So that's work that I'll be assessing and looking at with the chair and vice chair to look at the scope of what members would hope to achieve. And if it's possible, we'll do it. The other thing is about Health Watch. So I don't know yet what or who will absorb those functions of Health Watch as it is being abolished, decommissioned, and how we will have that patient voice. But what the chair and vice chair are 100% aware of is that this committee will be paying attention to the public voice and will be representing the public voice in this committee, and that becomes even more important in view of the decisions about Health Watch. So we know that there will be some mechanism to gather and hear that public voice. We just don't have a plan yet as to what exactly that will look like. As we begin to know more, we'll be talking about in this committee and making sure that we are hearing that and that it goes into our work program process.
Thank you.
On the question, it's just curiosity then, really. So they're getting rid of Health Watch, but one of the beauties of Health Watch was they can go to any health service without announcements to have a look at them and see how they're performing, whereas we can't. We have to tell them to come in and they can get themselves ready. Are the government going to transfer that power to us then? That would be brilliant if they did.
Through your chair.
Maybe
that there is a mechanism of hearing directly from patients that you know, preserves that independent voice. And that would, I agree with you, Councillor Girling, that would be very valuable.
Fingers crossed that'll put you in the driving seat as a committee, really will.
Well, whether that comes to health scrutiny, you know, there's no plan at this time, I think, for health scrutiny to take on the role of Health Watch. But, you know, members do have, you know, this committee has the opportunity to do reviews. This committee has the opportunity to, you know, set objectives for the kinds of scrutiny and kinds of topics that you want to look at deeply. So if that's something that you do want to do, then come and talk to me. We can have a conversation about how to make that happen. I know you're just here today. You know,
I am interested in my questions today.
But that's a good question, and it's good for all of us to know. You know, if there's something that members, you know, just burningly want to look at, and you want to hear from people, you know, we can figure out how to work it so that there's capacity to get the information that you want.
Thank you. Excellent.
Any more? All good. Okay, we'll now proceed to recommendations. First one, that the work programme and scrutiny priorities be noted. Can we vote on that one? Okay, thank you. Second one, that the authority be delegated to the health scrutiny lead to update the work programme as appropriate in the consultation with the chairman and vice chair and representatives of the relevant partner organisations, with any changes reported to the next meeting. Okay, vote on that one. All good, thank you. All that remains now is for me to thank the IBC, Healthcare Trust Partners, the Director of Public Health and the communities and members for attending this meeting and contributing in the discussions today. With that, I will now formally close the meeting and ask, please conclude the broadcast.